We're going to go ahead and get started with our last speaker. Our last speaker is Dr. Kevin Peng. His specialties are neurotology, ear surgery, and otolaryngology. Dr. Peng speaks English as well as Mandarin and Spanish. His education, medical school at UC San Diego. He did his internship at UCLA Medical Center, internship and residency at UCLA Medical Center, and his fellowship at the House Ear Clinic. He's board certified in neurotology. So,
Great.
Take it away.
Thank you. So thanks for sticking around to the bitter end, and sorry you have to listen to heavy talk for the last talk, but I'll try to make it interesting. As Catherine said, I work at the House Ear Clinic. We're in downtown Los Angeles, and I'm the medical director of the Children's Center there, so I see a lot of kids. And today I'm going to be talking about pediatric hearing loss. We're going to talk about congenital versus acquired causes of pediatric hearing loss, and then we'll talk about different interventions that we can do for these patients. This is my disclosure, which is not pertinent to this talk. And once again, we're just basically going to go over a bunch of causes of pediatric hearing loss, and we're going to break that down into congenital versus acquired, and I'll go over that in a second. And then finally go over some medical treatments, surgical treatments, and things that we like to think about for amplification. So congenital simply means present from birth, and that can be a genetic cause or in some cases a not genetic cause. For example, if a fetus contracts some sort of infection in utero, that could still be considered a congenital hearing loss, but it would not be considered a genetic hearing loss. Versus acquired, that's the other big category, and that refers to occurring after birth. So often we're referring to things like infections that occur in childhood, or probably the biggest category, middle ear conditions, such as otitis media with effusion, chronic otitis media, and the like. So let's start with congenital hearing loss. Again, broadly, we break it up into genetic causes and non-genetic causes. And when we're looking at just the genetic causes of congenital hearing loss, we recognize that there are lots of syndromes, which mean diseases where patients have a constellation of symptoms. So not just hearing loss, but other symptoms or perhaps some atypical physical features. Versus not syndromic, in which basically patients just have a gene-related hearing loss, but that gene isn't causing any other issues, such as I said before, either medical comorbidities or perhaps abnormal physical features. When we're talking about non-genetic hearing loss, there's a big category of infectious, non-genetic congenital hearing loss, and I listed a few other things on the slide too as the various etiologies for hearing loss that are not genetic but are present from birth, once again, congenital. So starting with the genetic causes, there are a bunch of syndromes that many of you are familiar with. I think one of the biggest syndromes that we encounter in clinical practice is Down syndrome or trisomy 21. Patients with Down syndrome typically have a conductive hearing loss because they have middle ear pathology, so it's rare for patients to have a sensorineural hearing loss from that. I've listed a variety of other syndromes here. Many of these other syndromes will have a sensorineural hearing loss. And we'll go over just a few of them, just the ones that are most pertinent. If we go to the non-syndromic, the biggest category, as many of you know, is GJB2, or connexin 26 mutations. That's the leading cause of autosomal recessive inherited hearing loss. And once again, we call it non-syndromic because GJB2 patients typically just have hearing loss, but they don't have other medical conditions that are associated with that mutation. So we don't call it a whole genetic syndrome. So how do we diagnose these genetic losses? Well, often we'll be ordering some testing, and there are many companies out there. For example, there's Fulgent, and there's GeneDx, and there are many other ones. There's one called Otoscope, developed at the University of Iowa. And when you order these tests, basically, we keep a stack of these collection boxes in our clinic. And typically just a buccal swab, so a swab inside the mouth, is all that's required to get enough cells to run these tests. So even on little kids, it's really easy to perform this testing. Then we take the kit and we send it right back to the company, the testing company, and then the testing company typically will run the insurance, make sure that there's coverage, and if there is, or if any authorizations have to be obtained, once those are obtained, then they'll run the testing and they'll send a report back to me. And what are the genes that are covered? I just copied and pasted one of the lists, and this isn't even the complete list of genes that get tested. So this is pretty much a shotgun approach in terms of testing for a whole bunch of different genes that can be associated with hearing loss. We have syndromes in here. We have non-syndromic causes of hearing loss, and all in all, they're close to probably about 200. I think each company has their own set of genes that they test for, although there is a huge overlap. So most labs will be testing for the same genes. When we get the reports back, sometimes we'll see variants of unknown significance. And what that means is that the lab suspects that there might be some hearing loss associated with a mutation that they've identified, but there might not be enough medical research out there to tell us definitively if that's associated with hearing loss. Once we get these reports back, I think it's important for patients to be sent to genetic counselors. As physicians, we have a little bit of knowledge in terms of inheritance, but really genetic counselors are able to delve deep into a patient's history, into their family history, and then counsel patients and their families about what to expect perhaps with offspring. So if there are any abnormalities, often I'll be sending patients off to genetic counselors. So I just reproduced over here the list of syndromes, and we're going to pick a few to talk about. So Down syndrome is a trisomy of the 21st chromosome, so there are 3 chromosomes instead of 2 in these patients. This is it's relatively rare for patients to have sensorineural hearing loss, once again, but it's relatively common to have some sort of hearing loss in Down syndrome patients. And the main reason is because patients will have some sort of conductive loss due to middle ear pathology. Their eustachian tubes are typically not robust, and they have overall just poor eustachian tube function and muscular function to pull the eustachian tubes open. So a lot of these patients will have effusion early in childhood, and later in childhood, even into adulthood, there's definitely a higher incidence of things like cholesteatoma or perforation, chronic ear issues. Here I have Pendred syndrome listed. This is a photograph of a goiter over on the right side. And a goiter, of course, is an enlarged thyroid gland. And one of the characteristics of Pendred syndrome is that patients will have what we call a euthyroid goiter. So their thyroid gland is typically large, but when their thyroid function is tested with lab tests, it actually turns out to be normal, hence the term euthyroid. So a lot of these Pendred syndrome patients will have a goiter, as well as normal thyroid function tests. When we get MRI scans or CT scans on these patients, we'll often see an enlarged vestibular aqueduct, and so that goes hand in hand with this mutation. When we have younger children with Pendred syndrome or the mutation in this gene that I've listed on the slide, often their thyroids may be of normal size, and it's only later in life that their thyroids start to become progressively enlarged. Because patients have an enlarged vestibular aqueduct, typically we'll counsel patients to try to avoid head trauma. And for kids, the main thing is contact sports. There's some controversy whether or not we should counsel patients to avoid pressure changes. That includes perhaps taking added precautions when flying or getting a myringotomy and tube performed before flying, as well as other things such as playing wind instruments or brass instruments, because occasionally those have been reported to be associated with enough of a pressure change that can actually cause a sudden sensorineural hearing loss when that pressure is transmitted from the enlarged vestibular aqueduct into the fine structures of the cochlea. So that's something that I'll discuss with all patients and parents of patients with Pendred syndrome. I want to talk briefly about microtia and atresia. Typically, microtia and atresia are genetic in nature. There are several genes that have been associated with microtia and atresia. Microtia, again, refers to the absence or malformation of the pinna, and typically we grade that on a scale where patients can have just a pinna that's slightly smaller than normal, ranging all the way down to, in some cases, not having a pinna at all. Atresia is when no external auditory canal, when the meatus and the canal are absent. And that's on a spectrum, too, where sometimes patients will have a slightly narrow external auditory canal and meatus, and other patients will have a frankly absent or atretic external auditory canal. These two can occur often in conjunction. So microtia and atresia will often happen in the same patient on the same side. Sometimes it'll be unilateral, sometimes it'll be bilateral, but it's also important to note that sometimes patients can just have microtia or just have atresia without the other one. And we'll delve deep into the different types of bone conduction surgery and devices later. But these patients are optimal patients for getting some sort of bone conduction rehabilitation. In terms of cosmetics, patients will often see a surgeon to talk about microtia surgery, basically reconstruction of the auricle or of the pinna. A variety of methods are used for that. Sometimes doctors will use rib cartilage to reconstruct the pinna, and other times Medpor or similar implants will be used basically to create that ear again. And the timing of those can be variable, but sometimes we'll fix the outside part first before doing the atresioplasty, or sometimes we'll do the atresioplasty first before addressing the pinna. And of course, there's the option for parents too to just leave everything alone and perhaps do whatever we wish with regards to hearing rehabilitation without doing any surgery. I think more and more we are really taking advantage of the very good bone conduction solutions that we have on the market rather than going straight to atresioplasty surgery. So we just covered a bunch of syndromes, and we touched briefly on microtia and atresia, which are genetic causes. So what are some other genetic causes that are not associated with syndromes? Well, the most common, as I said, is GJB2, or connexin 26 mutations, and that acronym stands for gap junction beta, beta 2 and beta 6. So those are the two most commonly mutated genes for autosomal recessive hearing loss. And once again, it's not syndromic, so these patients aren't having any abnormal physical features. They're typically not having any other associated medical issues. It's really this one gene that encodes for something within the inner ear is mutated, and so their hearing is affected. You might see the terminology DFN, and then so GJB2 and GJB6 mutations, or these connexin mutations, are together termed DFNB1. And if you're curious about when you see other DFN terminology, that stands for deafness, and by convention, A is used for autosomal dominant conditions. B is used, in this case, for autosomal recessive conditions, and there's also DFNX. And typically the numbers go by the date of discovery or of reporting of these conditions. So you might see in somebody's chart, for example, DFNA1 or DFNA2, and that refers to that specific gene mutation or disease. That's sort of getting down the weeds, but it's just important to note that DFNB1 is a synonym for these connexin mutations. Sometimes patients with either syndromic or non-syndromic hearing loss will have inner ear malformations. Another term for this is labyrinthine malformations or labyrinthine abnormalities or anomalies. And so on this slide here, I've shown that this patient has basically a common cavity deformation of the cochlea and the vestibule. So typically, if the internal auditory canal on this CT scan is sitting somewhere where my mouse is over here, and the cochlea you're supposed to see the turns of the cochlea anterior and the vestibule and the semicircular canals posterior. But this patient developed in utero with basically one large space for the inner ear structures. And so this is a common cavity malformation. This happens in both syndromic patients as well as non-syndromic patients. And in most cases, it's not of any particular importance in terms of how we treat the hearing loss, because typically we're going to be using amplification of some sort to treat this hearing loss. When we do need to resort to a cochlear implant, though, that can sometimes make cochlear implantation more difficult, or we have to select the electrode more carefully, depending on the degree of inner ear malformation that's present. So now let's go on to non-genetic. So we spent the past 10 minutes or so talking about the genetic causes of congenital hearing loss, so present at birth. So now we're going to talk about the present at birth hearing loss causes that are not genetic in nature. And when we're in medical school, we're all forced to remember this mnemonic, which is called TORCH. These are the infections that often lead to congenital hearing loss. So again, these are not genetic, meaning there is no mutation in the patient's genes, but typically they're getting one of these infections in utero while they're an embryo or fetus, and that's what's going to cause their hearing loss when they're born. So we're going to go over these each of these in the subsequent slides. Instead of going in the order of the mnemonic, we're just going to go in the order of the most common to the least common. So cytomegalovirus is a virus that's very common. Almost all of us, virtually all of us, have been infected with cytomegalovirus, in the sense that if you go into a lab and get antibodies drawn, for us adults, we're going to test positive. So we've been exposed and infected with this virus. But when a neonate has the virus, that can lead to very severe things, including hearing loss. It's rare to get CMV infection congenitally in developed countries, but it's a huge issue in developing countries. There's been talk in Europe, or at least in various countries in Europe, about screening universally for CMV infection at birth, and I think that's a reasonable thing to do. It's definitely not standard here in the United States, but one wonders if we might be able to pick up more hearing loss earlier, if that's the case. So in CMV, the cells that are affected, for example, I think this is a picture of like a lung cell, a pneumocyte. The cells will develop this funny appearance, like an owl eye appearance of the nucleus, and the cell will be enlarged. So that's one of the hallmarks of CMV if you're looking at a sample under the microscope. Patients with congenital CMV infection can have late onset or progressive hearing loss. So that's sort of scary because there actually aren't that many pediatric hearing loss conditions that are progressive, with the exception of perhaps CMV as one of the most common exceptions to that rule. About 13% of affected congenital CMV individuals will have hearing loss, and the cutoff really becomes about 3 weeks, where if a neonate, a baby, contracts CMV after 3 weeks, typically we don't consider that to be a congenital, like from birth infection. When neonates or kids get CMV infection later, it's a lot less serious, meaning there's a lot lower chance of getting hearing loss. On this slide, I've shown a picture of rubella. So there's a very low incidence of rubella with vaccination, and the rubella I'm referring to is congenital rubella, where the mother is infected and that gets passed down to the fetus. Again, it's really rarely seen in the United States, but in areas where vaccination isn't commonplace, rubella can be a serious issue. And rubella infection has a really high incidence of hearing loss, so up to 50% of affected babies will have a hearing loss. The hearing loss can be delayed in onset, so 6 to 12 months perhaps before it's fully diagnosed, although it makes you wonder if that's an issue with diagnosis rather than the onset of disease. I put this up here. I don't know how many of you remember the movie Trainspotting. It was from a while ago, and I watched it when I was very young, and I was very traumatized by it. But I remember thinking, what on earth is toxo? And then finally in medical school, I learned what toxo is. So as you remember, one of the characters in the film gets toxo, which is terrible. It's rare. It's rare to get toxo. I think in the days when HIV and AIDS were less well understood as they are now, it was more common. But certainly maternal toxoplasmosis, so moms getting infected with toxo and then passing it on to their kids, is a lot less common. Where we really see it now is basically exposure to cat feces or eating undercooked meat, and 20% of congenital toxo patients can have hearing loss. I put HSV here. HSV is very common. Again, going back to how we basically have been exposed to many viruses in our lifetimes. Almost all of us are carriers for HSV. I think it's been estimated to be like 80%, if not higher. And it's not an issue unless it's like congenital HSV, because then that becomes much more serious, or sometimes HSV in young infants. So HSV is the virus that causes cold sores and genital ulcers. Overall, the risk of hearing loss is low, and it's been described that HSV1 has a higher risk of hearing loss than HSV2. I put this slide in there just talking about auditory neuropathy spectrum disorder because it doesn't fit cleanly into any of the categories that I mentioned earlier. So ANSD, as many of you know, means that the cochlear function has to be normal. So typically, tests of hair cell function, such as otoacoustic emissions, are normal. But then ABR testing is abnormal. And it's been debated what the exact causes of ANSD are. The diagnosis itself is controversial to certain people. And the presentation can vary a lot. It can vary from a mild hearing loss to even profound hearing loss where a cochlear implant may be of benefit. There's an association with hyperbilirubinemia, so babies that have high bilirubin levels are more likely to have ANSD later. And typically we treat this with hearing amplification, but once again, sometimes these patients will require cochlear implantation. Okay, so now we're going to switch over to acquired hearing loss. So we had just spent all that previous time talking about congenital hearing loss, or hearing loss that is developing at birth or present at birth, and now we're going to go to acquired causes. So acquired causes basically means that a kid is born normally, but later in life they start developing a hearing loss due to whatever reason. Meningitis is a big cause that can cause sensorineural hearing loss. Viral infections, not congenital infections, which we talked about already, but infections that occur in childhood or infancy can cause hearing loss. Medications are notorious for causing hearing loss, although I think we know so much about many medications now that fortunately that's less common. And then finally, various types of trauma can of course cause hearing loss, and that would apply to adults too, not just pediatric patients. Moving on to a huge category, middle ear pathology can cause hearing loss, and we would categorize that under acquired, meaning the middle ear infections really just start after birth, of course, and so that does not count as a congenital hearing loss, hence being lumped together into the acquired category. So when we're talking about meningitis, the biggest culprit for hearing loss associated with meningitis is bacterial meningitis. I wrote down a couple of bacteria toward the bottom of the slide. Those are the two most common bacteria that have been associated with hearing loss when patients get bacterial meningitis. Fortunately, meningitis is pretty rare, but when it does happen in kids, there's a high incidence of hearing loss. It's also been debated whether adults have that same risk, and some people think that adults getting meningitis are also predisposed to getting hearing loss. I think that's screened for in a less robust fashion than we screen kids, however. And on the slide, I've written just the approximate percentage of hearing loss that's been estimated in the literature when patients get bacterial meningitis. There are other types of meningitis too. There's viral meningitis. There's what we call aseptic meningitis, where when they do a lumbar puncture, like is shown on this side, no bacteria or viruses grow out. So that's also a possibility. But definitely the biggest culprit is when patients have a bacterial meningitis. For patients with hearing loss after meningitis, if the hearing loss is severe to profound, we typically want to implant them early. And the main reason for that is because the cochlea can ossify. And when the cochlea ossifies, that means that the cochlear lumen gets filled with fibrous material and even overgrowth of bone, and that makes it extremely difficult, if not impossible, to implant an electrode. It's subtle, but on the scan, so this is an MRI scan, it's like a T2 weighted sequence, heavily T2 weighted sequence, and this is the internal auditory canal, which is where the hearing and balance nerves, the vestibulocochlear and facial nerves are traveling. And just anterior to this, we're supposed to see the cochlea. And the cochlea here is a little bit grayer, darker gray in signal than we would expect. So again, it's pretty subtle, but this patient was somebody that had early ossification of the cochlea. So again, for these kids, we want surgery to be performed within 6 to 12 months. Again, the earlier the better, after resolution of the meningitis, if they have been diagnosed with that severe or profound hearing loss. If it's bilateral, then we definitely want to treat them as for example, a bilateral congenital hearing loss patient, where we want to implant both ears to really take that opportunity while the cochleas are still patent. Just some signs and symptoms of meningitis. A lot of these pediatric patients may be able to tell you that they have a severe headache, but for little kids who still have fontanelles, a bulging fontanelle is a bad sign. Even in adults, patients will have fever, light sensitivity, stiff neck, nausea and vomiting, and it can get even more serious. We talked about how for meningitis, typically patients need to go to the ER and they need to get a lumbar puncture. Typically a culture is performed of the spinal fluid that's obtained from the lumbar puncture, and meningitis is typically treated in the hospital setting where patients are getting antibiotics and sometimes steroids to help with the inflammation. Again, it's difficult to test for hearing loss, but it's super important that if you know a patient has a history of meningitis and they're coming to see you, that's on our radar, that they may have hearing loss just at that moment, and it could even be progressive in terms of the ossification. And I know it's hard testing inpatients for hearing loss, but in an ideal world, we'd be testing people, patients inside hospitals for hearing loss when we're treating them. So we'll go back to a couple of viruses. Rubella, again, as I mentioned earlier, if a kid gets rubella in childhood, despite vaccination, for example, or I suppose if they're unvaccinated, fortunately there's only a low risk of getting hearing loss. It's only the congenital rubella patients that have a very high incidence, maybe even up to 50% of hearing loss. And again, measles and mumps, part of the reason that there's been such a push over the past several decades to vaccinate people is because there is an incidence of hearing loss, albeit low, but if enough people get them, then we're having a lot of healthcare burden from something that could theoretically be preventable. So the MMR vaccine, really, one of the main things that it helps prevent against is hearing loss in these susceptible kids. So just a quick note about some other causes of hearing loss that we would consider acquired. So again, a kid is born with normal hearing, but later they lose their hearing. What could that be due to? Well, ototoxic medications, so some antibiotics, although rarely the ones that we use commonly, but still some of them, I suppose. Ototoxic medications can cause hearing loss. Various forms of chemotherapy can cause hearing loss. If somebody has a severe closed head trauma, that can lead to a cochlear concussion, and that will usually lead to a sensorineural hearing loss. There might be a temporary threshold shift, or that might turn permanent. And if I have a patient who's a teenager and they're talking to me about going to concerts, I'll typically tell them to wear hearing protection to try to avoid acoustic trauma. And I think that's still something that we all need to do better on in terms of making sure our patients know that that's one of the prime preventable reasons for getting hearing loss. So we're going to switch over and talk about some interventions. Alan told me to talk about medical and surgical interventions, so we're going to talk about medical first. When we're talking about medical interventions, there aren't that many things we can do for hearing loss in terms of the medical perspective, aside from fitting somebody with appropriate amplification. Of course, if they have some sort of infection or fluid, then we need to treat that. So if they have a middle ear issue, we need to treat the middle ear issue, and sometimes that will require medicines. I think in terms of other medical interventions, there's gene therapy that's been discussed for decades, and I think it's still pretty preliminary, as in we don't have any great gene therapy on the market to be treating basically genetic causes of hearing loss. But probably in our lifetimes, we're going to see some major strides being made in that regard. I just pasted a screenshot from one of the papers that has a good overview, although it's about 5 years old now, of where we stand on gene therapy for hearing loss. I briefly mentioned that, of course, we want to fit patients with appropriate amplification, and we'll be talking about some non-surgical bone conduction options in the next slides. So moving on to surgical interventions, this captures a lot of stuff, including all the bone conduction stuff, which I'm going to lump together with the surgical ones, both the non-surgical and surgical bone conduction devices. And so I've broken this down into discussion of several categories. We do surgery for middle ear pathology. We do surgery to put in implants, and those implants can be bone conduction implants or cochlear implants, broadly speaking. What's the most common middle ear pathology in kids? Well, we see chronic otitis media with effusion. Depending on who you ask, some people just leave out the chronic part and they call it OME, or otitis media with effusion. It means the exact same thing. Some people call it serous otitis media. I suppose some people might even call it mucoid otitis media, but we all use that basically to refer to the same thing, which is kids having fluid behind their eardrums, and that fluid is not actively infected, but it's causing a hearing loss and a flat tymp. When it does get infected, then we call it AOM, or acute otitis media. And then typically in the ear world, or in the otology world, when we say chronic otitis media, but we don't say the word effusion, we're referring to some sort of chronic condition that requires surgery, like a TM perforation or a cholesteatoma. And so on this slide here, I've actually listed a photo of acute otitis media. So it's not just an effusion. When we see an effusion on otoscopy, often the eardrum you can still see through, and it might be a little bit yellow, or you might see some bubbles. But when it's full and opaque and pink or red, we think that that's closer to acute otitis media. So this otoscopy photo is of acute otitis media. I don't expect you to read the small text. I grabbed the most salient parts here, but this is a screenshot from the American Academy of Otolaryngology's guidelines for when to do myringotomy and tubes on patients. So let's go over what I think are the most salient indications. The first is if we know there's an effusion present, either by tympanometry or by examination or both, and there's a hearing loss greater than 30 decibels, then myringotomy and tube is indicated. If there's been an effusion present for 3 months, regardless of the hearing status, we want those patients to have a tube also. If there's recurrent acute otitis media, 3 and 6 months or 4 and 12 months, then those patients also need a tube. And some of those acute otitis media patients will actually have normal eardrums in between their infections, but we know that putting in a tube actually reduces the risk of getting future infections. So that's why we recommend myringotomy and tubes in those patients. And then finally, some patients with cranial facial abnormalities. We'll talk briefly about cleft lip and cleft palate, but that's probably one of the most common ones. Those patients will also benefit from myringotomy and tubes. This is a photograph of a Sheehy ventilation tube. And so as many of you know, these tubes are really small. They're like 1.3 millimeters in diameter. So they're tiny little tubes. We use a microscope, as many of you already know, to put them in. For kids, we have to go to the operating room. Like, we don't want to subject kids to do that in the office, of course. But for adults who need pressure equalization tubes, actually we can do that in the office with just a little bit of anesthesia on the eardrum. I think what I emphasize to patients' parents is, look, we have to go to the operating room, and it's an outpatient procedure. It's really fast. The kid might be a little bit groggy, or act maybe a little bit differently for the rest of the day because they've been put under and they had to get up from that. But overall, it's pretty simple. I think one of the big healthcare burdens of doing myringotomies and tubes is kids have to see their pediatrician, they have to get clearance, and then it takes a whole lot of planning to actually get this done. But it's definitely very important to do if the indications are met. This is a photo of a tube and an eardrum. There's fluid coming out of this tube. And so I wrote at the bottom of the slide, there's a risk of persistent fluid after ear tubes. And that happens in a small percentage of patients, maybe 5 to 10%. And we're not entirely sure why that's the case, why some people have persistent fluid after tubes. The thought is, hopefully, once you put in a tube, the fluid that's in there is going to come out, and then there's going to be more aeration going in and pressure equalization so fluid doesn't recur. But if fluid keeps on coming out, often I'll be having patients and their parents try to use some sort of ear drops. Ciprodex is the most common ear drop that's out there, but there are many forms. There's ofloxacin. There's other types of ear drops that are safe for use in the middle ear. And I would consider using ear drops after tubes if somebody is having persistent drainage. According to our academy, in any case, the presence of tubes doesn't mean that kids can't swim. They actually can, and the recommendation actually is if you're going into a chlorinated pool, you're fine to swim without hearing protection. If you're going to be swimming in like a non-chlorinated setting, like a lake or a stream or even the ocean, I tell kids, if they want to go splashing around at the beach, or if they're diving, so there's a lot of pressure associated with their water activity, then they should wear earplugs. But otherwise, swimming in a chlorinated pool is fine, no earplugs for kids that have tubes. Cleft lip and palate. Cleft lip can occur with cleft palate. That's the most common presentation. But sometimes patients will just have cleft lip or just have cleft palate. If somebody just has cleft lip, that actually doesn't necessarily increase their risk of getting otitis media. But anytime the palate is affected, that increases their risk. And as many of you know, that's because the muscles that go to the eustachian tubes rely on an intact palate to be tugging the eustachian tubes open. And when that's not there, then kids will have effusions. There's a super high rate of having otitis media in kids with cleft lip, cleft palate. And I think a multidisciplinary approach is important, where the cleft team will often be, for example, sending me the information about their recommendations. We'll make sure that the patient gets ear treatment as necessary, and then the audiogram is performed, and it gets sent back to the cleft team so that everybody's on the same page. So moving on to chronic otitis media. Chronic otitis media typically refers to, again, as I said before, some irreversible change to the ear that often will require surgery. So the most common types of chronic otitis media are infections related to eardrum perforation, cholesteatoma, which, as many of you know, means that the skin of the eardrum is invaginating within the middle ear and going into the mastoid. And then sometimes patients will just have chronic otomastoiditis, so chronic inflammation in their middle ear and mastoid, but without a perforation. Granted, that's sort of rare. Like, I'll have a few cases each year like that only. And for most cases of COM, typically we're going to need some sort of surgery. This is a photograph from inside the operating room of a tympanoplasty, and so we will perform this in kids too, although I typically like to wait until pediatric patients are around puberty to make sure that the eustachian tube function is optimized. But if parents, for example, want their kid to swim without any issues, then I may consider tympanoplasty much younger if necessary. And so this is actually the temporalis fascia. We make an incision typically behind the ear, and we take a piece of temporalis fascia from the side of the muscle, and we use that as the new eardrum. So that's shown here. And I tell parents and patients that typically after a couple of months, that's when their hearing starts to improve. So it doesn't improve right away. Typically, tympanoplasty is done under general anesthesia, and it's an outpatient procedure, so patients can go home the same day. We talked about cholesteatoma briefly. For cholesteatoma patients, we have to do a mastoidectomy. So this is the mastoidectomy done here. This patient had a small mastoid because sometimes we have more pneumatization in the mastoid air cells and sometimes we have less. If we have less, that means the mastoidectomy, the part that I'm opening up with a drill, is also smaller. And so I have to perform a mastoidectomy and usually do a tympanoplasty, so we call that in medical terms a TIMP mastoid for short, to remove the cholesteatoma and basically repair the eardrum. The reason cholesteatoma is an issue is because there's a layer of live skin that's been retracted into the eardrum and mastoid, and that's shedding dead skin cells, and that basically leads to a ball of dead skin, which we call cholesteatoma. And often we'll be performing surgery in stages, where the first stage is to remove the cholesteatoma, and the second stage is to do the ossiculoplasty, to basically put in a prosthesis to replace the malleus and incus, or sometimes to replace all three ossicles. So we talked about surgery basically for chronic otitis media. Now we're going to switch gears and talk about the different types of implants and devices that we have at our disposal. I think everyone in this room is arguably even more familiar than I am with these devices, but there are a lot of bone conduction devices on the market. One of the main indications is, of course, a conductive hearing loss. But we consider bone conduction devices for single-sided deafness, and in certain cases, asymmetric hearing loss also. So all of those can be valid indications. When I'm seeing a patient first and discussing this with them, often they'll have no idea what I'm referring to, but some patients actually have already started to use these sorts of hearing devices. I think they used to be called aftershocks, but now they're just called shocks, but they're bone conduction headphones that are marketed toward runners, for example. And sometimes, if I tell patients that that's what a bone conduction device is, they get it right away. If they don't, then of course I have to rely on all of you to be discussing with the patient and perhaps trialing with the patient what a bone conduction device might sound like. So the tried and true are the percutaneous devices. Those have been around for a long time. And the last I checked, the Baha and Ponto are FDA approved for greater than, equal to or greater than or equal to 5 years of age, so for pediatric patients. The newer ones are the three that I've written over here in alphabetical order: Bone Bridge, Ossia, and the new one, Sentio, which is just coming out. And to the best of my knowledge, the FDA approvals for the age ranges are listed on the slide there. And then there are the non-implanted options, again in alphabetical order, not playing any favorites. There's Adhere, the soft bands for the Baha and the Ponto, and then Cochlear has the Sound Arc. So this is a diagram of the, this one over here with the green screw is the Ponto device. We'll talk about that one first. Percutaneous, bone conduction means through and through the skin. So these patients will, as you know, have a little button, a little screw that's been screwed on to their skull and osseointegrated there, and that's where they snap on the processor. Usually we have to wait 3 months after surgery to osseointegrate fully, so patients need to have surgery and then wait. I think one of the main issues with percutaneous bone conduction, these tried and true versions that have been around for a couple of decades at least, is that there are often infections around the surgical site, and unfortunately that really bothers patients. So there's overgrowth of skin, there's chronic irritation in that circular area of skin just around where the implant is. This is, of course, like an ideal picture where there's no irritation, but it's rare that we see that. I tell patients that surgery is really fast. It's like less than an hour. Typically for children, they need general anesthesia. For adults, either general or local anesthesia would be fine. When we first started doing these, we weren't as perhaps concerned about the abutment length. We would simply roll with it. We might perform some skinning, some thinning of the scalp to try to make sure that the implant doesn't overgrow. But over time, we've realized that basically having a long abutment, as well as having perhaps some technological advances in the materials of the implants, has basically helped minimize overgrowth and skin issues. So moving on to transcutaneous bone conduction. So these are the newer devices. I think the photo that I have here is the Cochlear Ossia. And we call it transcutaneous because there's a magnetic connection between the internal and the external components. And the skin is intact over the implant. And so that's a huge advantage because patients won't have infectious issues. Again, if the skin is closed, that means typically no bacteria is getting in anywhere near the bone conducted implant, and then so that leads to no issues with infection, drainage, things like that. The downside, though, is that these devices are perhaps larger. So when we do an osseous surgery, for example, we have to first put in the osseo-integrated implant. We have to screw that into the skull. And then through that incision, then we're putting in this silicone envelope of the implant and then screwing the processor onto the implant. And that leads to a bump maybe about 1/4 inch in thickness or maybe a little bit less underneath the skin. And I think for patients that have a lot of hair, that's not an issue. I think for pediatric patients, that bump is very noticeable. I think it's a small price to pay, of course, but that's one of perhaps the downsides of transcutaneous bone conduction. And again, there's a magnetic coupling similar to cochlear implants between the processor on the outside and the internal device. Here's one of the competitors, the Bone Bridge. For some of these devices, drilling might be required. So for example, for the Bone Bridge, there's a lot of drilling that we need to perform. Some surgeons are comfortable with it, and other surgeons perhaps are less comfortable. So if you're working with a physician or a surgeon regarding these devices, you might have to ask them about their familiarity with the devices and how comfortable they are with doing the surgery, because that might actually impact your choice of implant. And then there are subtle differences with these different devices with regards to how the surgery is done, where the incision is, etc. This is the newest device on the market. I haven't used it yet. It's the Oticon Sentio. Generally speaking, and I don't have memorized the exact fitting ranges for each of the devices, but generally speaking, these can aid up to about 45 or 55 decibels for the bone line. So if the bone line is 45 or 55 decibels or better, typically these devices can be used. And if you have any questions about a specific audiogram, of course, I think the reps are super helpful, and they can help you navigate whether or not one of the devices you're thinking about is appropriate for your patient. After we do ear surgery, we typically put on the dressing, the glass cock dressing named after a famous ear surgeon who's now deceased. And these bone conduction surgeries are typically pretty fast for the transcutaneous devices. It's done under general anesthesia. There's usually a decent sized incision that has to be performed and enough dissection that has to be performed to get the implant in and seated. And depending on the device, there are different recommendations on when you can activate the device, so when the device can be fitted and the processor turned on. I'll be seeing these patients usually back in like 1 to 2 weeks, like with most of my surgeries, just for a wound check to make sure there's no infections. And I wrote here non-absorbing versus absorbing sutures. I think sometimes we'll actually have to put in sutures that need to be taken out for these devices, whereas most of the time for our surgeries, we actually just use all absorbing sutures. And then finally, I want to talk about cochlear implantation. The indications really are for severe to profound sensorineural hearing loss, of course. For congenital patients, I think that depending on who you ask, I think a reasonable minimum age for cochlear implantation is about 6 months. Patients have to be healthy enough to undergo anesthesia, so patients with syndromes may not be healthy enough to be having surgery. For patients that have acquired severe or profound sensorineural hearing loss, of course, that's a great indication for CI as well, and we can consider it for SSD patients. That, I think, is just beginning to hit the pediatric world, whereas in adults, we've been doing SSD CIs for a few years now, with good success with respect to authorizations. I think my computer restarted itself. It's not promising. Catherine, you don't happen to have a computer, do you? Or does anyone have a computer? No. Yeah, I do. The most recent file. Should we put it up here? Or? Yeah. Okay. Great. Maybe take some Q&A. All right. I got it. I just have a few more slides left, but does anybody have any questions right now? If since we have maybe a little bit of time before my slides get back up. Yes.
When you were talking about adults for surgery and kids have to go under general anesthesia, what age would you consider adult?
I think anywhere up to probably 85, 90 years of age.
Oh, no, I mean the lowest end of adult.
Lowest level, 18.
Huh?
18.
18, okay, all right, okay.
My convention, but that's sort of arbitrary. Oh, thanks. All right, back in business. Okay, so I just wanted to, this is the numbered letter from CCS, as they call it. And so I just want to go over the CCS guidelines. I know not everybody who's attending necessarily practices in California, but many of us do. And so these are the guidelines that CCS has stated for doing cochlear implantation for CCS patients. The patients have to have a bilateral hearing loss or ANSD. And they say that CI surgery evaluations shouldn't be withheld if kids aren't meeting their milestones, because there's the concern that if we wait too long, then we're going to miss a good window. And the criteria, once again, are there has to be either a bilateral profound sensory nerve hearing loss or a unilateral hearing loss with an affected contralateral ear. And of course, the CCS wants us to have a good trial of hearing aids and maximum amplification and basically no benefit. So I think those are pretty reasonable guidelines. I think one of the main things is that CCS isn't really covering SSD, and they're covering asymmetric hearing loss if it's bad enough on the contralateral side, but not pure SSD. This is a photo of what it might look like during the cochlear implant surgery. So a CI might take 1 or 2 hours, sometimes less if things are going great. It's under general anesthesia, and I talk to patients about the risks, which include pain, infection, bleeding that can happen with any surgery. Okay. Makes me wonder. The facial nerve injury, fortunately, is extremely rare when we do ear surgery. But the facial nerve, as you all know, is very close to where the ear is, where the inner ear is. So I mentioned to patients that they could potentially, perhaps 1 in 100,000 or 1 in 10,000 chance of having some sort of facial weakness after surgery. Dizziness is really common after CI surgery. I think for kids, the good thing is kids are less able to articulate that. Whereas when we do a CI on an adult, I think adults are readily able to notice when they have a disturbance in their vestibular system. And then finally, the quarter-tympani nerve is close to where we're putting in the cochlear implant. So some patients will have a metallic taste on the side of their tongue, on the side that we're doing the implant on. This is a photo from surgery of the electrode getting put in. Typically, we put it in through the round window. That's been sort of a development that's happened over probably the past 5 or 10 years. Prior to that, we were often drilling into the cochlea and making a separate opening close to the round window to put in the electrode. The 3 implant companies on the market now call it different things, but we perform intraoperative electrocochleography, at least at our clinic, to make sure that the implant is where we want it to be. And then some centers will also perform an X-ray when we're actually doing the surgery after the implant's put in, so you can see the electrode coiling, which once again is sort of a safeguard that the electrode is likely in the intended location inside the cochlea. Activation is usually about 3 to 4 weeks after surgery. Depends on what the surgeon prefers as well as what the audiologist prefers. And one of the reasons we wait is because we want the scalp to have healed completely, for there not to be much edema or swelling of the scalp, so that fitting is easier. And then I tell patients that it takes about 6 to 12 months to really get to great cochlear implant functioning, to as good as it's going to get. But depending on who you ask, that number may vary. I think some people hit the ground running and do great, and other patients really take a long time to maximize their function with a CI. Again, in summary, we talked about different causes of hearing loss in pediatric patients. There's the big category of congenital loss, which is present at birth, versus acquired hearing loss, which is what happens after birth. And then we talked about how congenital losses are broken up into genetic causes and non-genetic causes, and we talked about syndromes versus isolated genes that don't cause syndromes. We talked about how acquired causes include things like meningitis or other infections, and then there's the big category of chronic otitis media, including middle ear fluid. And then considerations, again, depends on the severity of the hearing loss or what the underlying cause is. If it's something medically treatable, then we treat that medically. And then, again, we went over the different types of hearing rehabilitation options, including hearing aids, as well as various implants. So thank you very much for staying to the end and listening to my presentation. If you have any other questions, I'd be happy to take it now. Thanks. Yes. I can probably just repeat the question if I can hear you from up here. So.
Few questions. What is the minimum age for considering tube placement?
I think it depends on the etiology. So, for example, if a patient's undergoing cleft lip and cleft palate surgery, and we happen to be at the same center, we might even consider putting in a tube in those patients when they're going in for that surgery. And that can be as early as just a few months of life. If patients don't have cleft lip, cleft palate, often they're developing effusions slightly later, so about 1.5 or 2 years of age. And definitely by then, there's no problem in doing surgery on those individuals.
Okay, thank you. And you mentioned in kids with atresia, bone conduction implants preferred over actually opening up the ear canal. What's the reason behind? Is it due to complications or low success rate?
Good question. I think it's a couple of things. The success rate. I think if we do atresioplasty, which is opening up the ear canal, it's successful in a majority of cases. We're able to get it open. We're able to get better air-conducted hearing through that. But the hearing typically is not at normal levels. Like there's still some conductive loss remaining because often the ossicles are slightly malformed and we're relying either on those ossicles or a prosthesis to be conducting the sound. The second main reason is because when we have an atresioplasty cavity, those patients are prone to infections. So those patients have a really hard time swimming. And so I think that becomes a huge deal for patients and their families. And I think the combination of those two has really moved us away from doing atresioplasty surgeries as commonly as we used to do it in the past.
And how often do you see congenital inner ear malformations?
I think overall it's rare. Meaning it's maybe, I think, 5% of patients that come into my practice with a congenital hearing loss. So I think in that sense, just from, and I don't know what the exact numbers are reported in the literature in terms of all congenital sensory hearing loss, what is the chance of having an inner ear malformation, but it doesn't happen that often. I do get an MRI scan typically, maybe a CT scan, but I typically get an MRI scan as a matter of routine on virtually all patients that are coming to me with a pediatric hearing loss. So I don't think that's due to lack of screening. We're definitely screening for it. It's just that actually, most of the time, the cochlea looks morphologically normal.
Okay, great. Thank you. Yeah, that's all. Thank you.
Thank you.
Yeah, we have some questions from online. The first question is about the implantation. Is there a way to measure or estimate whether or not the electrode array will be too long or not fit into cochlea?
There are technologies available through at least one implant company where we're trying to measure the duct length, the cochlear duct length, and that can be considered, especially if you want to use an electrode that you know is of a certain length. So that can be done. So there's that strategy. Whether or not that's commonly done or not, I think is up for debate. But I think that's something that's promising in terms of, I think that we're only going to get better with regards to becoming more tailored with respect to electrode choice based on a patient's anatomy.
Another question is, what is the mechanism for ossification status post-meningitis, and why does it do this?
We think that it's inflammation inside the cochlea itself. So there's enough inflammation, and somehow that triggers bony growth or bony overgrowth, and then that basically fills up the cochlea with more bone. So it really boils down to more inflammation.
Are we all finished?
I think so.
Yeah, great.
Thank you.
Thank you very much.